Okay, good evening, everyone. Good afternoon, wherever you are. Thanks for joining. We'll give it just 1 minute for everyone to be inside the call and for all the microphones, because initially they start with the mics on for a few seconds before you get muted. Please remember, this is an interactive session, so anytime you have a question or comment, please do unmute your microphone and you can speak up and stop me at any time. So we'll just give it a few more seconds for everyone to join. Again, thank you for joining this last session of the ACE courses series in collaboration with PASCAR. Okay, so today's session is for the eco interventional session. Basically, okay, I guess I am also unmuted. So can you hear me now? Okay, yes. So we will, thanks, Alma. So we will simply talk about how 4D echo can help during structural heart interventions and during complex procedures that require guidance, basically during such interventions. So we'll talk about structural heart disease. What are the different types of procedures in terms of structural heart or percutaneous procedures? We'll talk about the role of different imaging modalities. We'll talk about the 4D tools that are helpful in the visualization, navigation, and quantification also when it comes to guidance and assessment, pre-assessment guidance, and of course post-procedural assessment as well. So we'll talk about multidimensional imaging or multiplane imaging, such as biplane, triplane. We'll talk about 4D volume acquisition. We'll talk about 4D navigation and cropping. We'll talk a little bit about quantification, such as our valvular quantifications, predominantly aortic valve, mitral valve, tricuspid valve. And then we'll talk about fusion technologies and how they can add value in such structural heart interventions, different technologies, and the advantage of each. And we'll show also some clinical cases. So first thing is, what is structural heart disease? Of course, it's an issue with the tissues or the valves that is usually congenital, but of course some will develop later in life, such as aortic valve stenosis, ASDs, and PFOs, valve disease in general, regurgitation, degenerative disease, left ventricular hypertrophy, cardiomyopathies, Marfan syndrome, myocarditis. All these are considered a structural heart disease that can again be either congenital or develop later in life. Sorry. So a structural heart procedure or a percutaneous procedure is where we use catheters to perform such procedures without the need of surgery, of course, and of course, with the development of new devices and new implants, more and more people are using more tools, more structural heart procedures rather than surgery whenever possible. Some of the common structural heart procedures that are being used nowadays, balloon valvuloplasty, which has been for forever, for a very long time. TAVR, which is one of the most common structural heart procedures in the region and across the globe. Then you have the transcatheter mitral valve repairs, such as mitral valve clip, valve-in-valve, even total replacements, such as the Tendyne implants more recently, even paravalvular leak repairs. Tricuspid, for example, cusp repairs, annular repairs for mitral tricuspid, ASD, VSD, closure devices, PDA occlusions, LA appendage occlusion, and so forth. And of course, transseptal puncture, which is used in most of the procedures. There are also other procedures, but it's not necessarily where for the echo is the best modality, but they can also be considered as structural procedures that echo pre-assessment can help, not necessarily as the only modality. In terms of imaging modalities for structural heart interventions, of course, there is the conventional, traditional, the interventional modality, which is fluoroscopy. Since the very first use of fluoroscopy for coronary artery diagnosis, assessment, and later, of course, PTCI with the coronary artery stenting procedures, and more recently, of course, with structural heart disease implants. Fluoroscopy is also used for guidance as the traditional modality of choice. Echo, of course, is very helpful. Can be an adjunct or sometimes a replacement for the fluoro in the pre-procedure assessment, of course, and even during the procedure for guidance, depending on the procedure. And of course, the advantage of echo, two advantages, of course, over fluoroscopy is the 3D structural or surface rendering and the ability to do 2D slicing in addition to the real-time imaging, continuous imaging, as well as, of course, the obvious, which is zero radiation when it comes to echo. CT, of course, is also the gold standard in terms of detailed anatomy as well as calcification, regardless of what type of procedure is being done or diagnosis or assessments being done. CT can always be very helpful in the pre-procedure assessment and the planning of such interventions. So you can see here, this is the role of each of the imaging modalities can play pre-procedure and during the procedure. Of course, echo has also is a link between pre-procedure and procedure and during procedure, because it can be used pre-procedure, it can be used during procedure. Of course, CT can only be used pre-procedure. Fluoro is usually during the procedure. If you start fluoro, then you might as well just do the procedure. So, for example, for TAVI or TAVR, CT is the optimal, the ideal tool for sizing assessment, planning the implant. Fluoro is the ideal imaging modality for guidance during the procedure. Echo does not play a huge role, but for example, mitral clip, CT does not help much. As you know, you cannot see the open valves in CT, or you cannot see the leaflet tips in CT and the motion of the leaflet tips, but echo can be a huge tool pre and of course during assessment. Fluoro is not also the optimal tool for annular repair planning. Of course, CT is the ideal in terms of detail anatomical resolution. Echo ideal for guidance during the procedure. Fluoro does not help much in that aspect. LA appendage, CT can be a great tool, but echo is an ideal tool, and likewise fluoro, as you can see, and different procedures as well that are out there in the market. So the challenge is, of course, the anatomy is complex. That's the most well-known channel. Every patient is different. Every case is different. The sizing of the devices is very critical in that aspect. And of course, the navigating around the different parts is also complex, because we're doing percutaneous procedure. And of course, the goals are to shorten the procedure time, decrease radiation, and increase accuracy in all kinds of procedures. And this is where different modalities can help in different aspects in the planning phase. It's very important to have the right anatomy, the right planning, the right sizing of devices that are going to be used, and also the introduction. How are we going to introduce the catheters and so forth? Guidance also during the procedure for proper landing zones, of course, for the device, and assessment, post-procedure assessment, whether it's functional or just anatomical. Is there a residual regurg? Is there a caused stenosis or a secondary stenosis due to too many clips, for example, in a mitral valve clip? So again, different imaging modalities can help in that aspect. So what about echo? Of course, since we are talking about 4D echo tools and how we can help, and we can help in 3 aspects: visualization, navigation, and of course, quantification. So in terms of visualization, of course, it is image quality for echo is very important. It's very important to have the right anatomical resolution for the structures at hand. So in terms of visualization, we have a technology called C-Sound with true confocal imaging and adaptive contrast enhancement. These technologies bring us the best resolution when it comes to just normal 2D as well as 3D. You can see the resolution because of the C-Sound software-based beamformer, as well as the true confocal imaging. As you can see the image on the left, the conventional ultrasound image is that you have a focal zone, and ideally almost every echo machine can give you a good resolution in the center of the image, but nothing good can be, or nothing that good can be in the proximal area. And if your focal zone is higher than this point, the any tissue beyond the focal zone will be completely blurry and out of focus. While here on the image on the right with true confocal imaging, you can see pixel-based focusing throughout the field of view from top to bottom. This is again using the latest technologies and even AI signal processing in order to bring the best resolution for us. There's also a probe technology, of course, the matrix 4D probe technology, which enable us to have a matrix surface of elements that allow us to have either multi-planar rendering by activating one line or one row or one column of the elements, resulting in 2 planes simultaneously or even 3 planes simultaneously. In addition, to have a pyramid-shaped volume acquisition of the entire area of interest that we are trying to visualize. So one example again of quick visualization navigation, having multi-dimensional imaging or biplane imaging, where you can have a long axis and a short axis also at the same time, regardless of the field of view, whether it's transthoracic or transesophageal. If you're doing apical views, triplane imaging also can be very helpful, or even for T views, you can have a 4-chamber, 2-chamber, and a 3-chamber view all simultaneously at the same time. You can view different angles of the area or the structure of interest. Then you have the 4D acquisition. You can acquire in single beat or multi-beat, and you can acquire one specific area or a full zoomed volume. If you're doing, for example, chamber quantification, you want to do LV or right ventricular quantification with strain, for example, LV strain, then you sometimes have to do multi-beat. But if you're doing structural heart procedure, chances are you're focusing on a specific zone that you want to intervene in. That means you really don't need a huge volume. You need a targeted volume. So you don't need multi-beat. You can use just single beat. And with that, there's a tool called VMAX, where you are able to have up to 5 times the frame rate. That enable us to have very high frame rate as well as spatial resolution at the same time, as you can see in these examples for the aorta and this mitral valve with a percutaneous with the paravalvular leak during, as you can see, a percutaneous attempt to have this paravalvular leak closed with an Amplatzer device. So this eliminates, again, the need of ECG gating and stitching artifacts that could happen because during structural procedures, we don't have the privilege to acquire multi-beat and start replaying and cropping and navigating, we want to see everything right away on the spot, and that's where these tools come in. HD Live, for example, give us what we call, or what I like to call, a streetlight effect with the shadowing, as you can see here, that give us a depth perception. Of course, again, as mentioned during the last sessions, when we are doing 3D surface rendering, we are looking actually at a 2D monitor at the end of the day. So something has to tell me what is what is near, what is far, and that's where the color coding comes in. You can see the brighter yellow or pink means near structure. The more grayish, darker color is a further structure, but there's also a shadowing effect that also gives us a little bit more information. In addition, newer technologies such as FlexiLight, where we have a torch effect. This is the light source, kind of like the endoscopy light source effect. The light source is inside the heart, is inside the structure you're looking at, and you can see even a stronger shadowing effect because it's like carrying a torch with you. And you can even have the light source behind the structure so you can see the transparency of the structure and even the opacity if there's calcification. And you can see, again, it gives you a great deal of depth perception. When you move this light source, you can see, for example, this part of the papillary is much nearer, much far from the back wall with this huge shadow that is reflected upon the back wall once we bring it closer, once we bring the light source on top of it. Then additional, this is another example of the help of FlexiLight. This is FlexiLight. The light source is actually inside the atrium, and you can see the arrow. We are looking from the atrial position. In other words, the surgical view of this mitral valve post clip. You can see the clip has been there. You can see there is no catheter from 2D, and from 3D there is no catheter. However, in this image on the right, this is the same image looking from the same angle. The difference here is that the light source is actually inside the ventricle. We can even appreciate the opacity and the residual opening, of course, of the mitral valve during diastole. And you can see the opacity here of this center between P1 and P2, and that's exactly A2 and P2, I'm sorry. And that's exactly where the clip is. Another tool here, it's called HD Color, where you can minimize the opacity or make the high velocities transparent without compromising the opacity of the high velocity jets. That means the low velocities, which are usually displaced blood or swirling blood, that is not the significant jet, but the low velocities can be transparent, maintaining the opacity of the high velocities, which are usually the significant jets. And this is, again, very helpful in terms of visualizing different structures with color Doppler, whether it's static or dynamic real-time 4D with color Doppler, as you can see in this case. Then in terms of workflow, we need tools that can bring us the imaging that we need quickly, and the cropping and the area of interest quicker, rather than wasting time when we are trying to do 4D guidance for such complex procedures. Lots of these tools are available, such as FlexiZoom, where we can pre-acquisition plan what is the area of interest. As in this case, if you try to acquire this full heart, you will not have the best optimal resolution and the optimal frame rate. So in order to get the optimal resolution for your target area, which is in this case, for example, mitral valve, I can actually place a 4D zoom prepare, have a zoom box around the mitral valve from this classical 4-chamber, and this image, which is perpendicular to it, which is between 2-chamber and 3-chamber, deciding the thickness of the image, because the first color box is how I can decide the width and the height of the color box, but the second image on the right is how I decide how thick this structure is. And then the moment I start cropping 4D, then I'll immediately have the right data set with infasa of this structure at hand. This is something that you can do manually to zoom or crop the required area of interest. There's also automated tool which is called FlexiViews, if you click on the touch screen, you can, the same image that we started with the 4-chamber image, if you just click mitral valve 4D zoom, then again, you will get the same 4D acquisition within FASA. But if you are, for example, in mediasesophageal long axis, you click on aortic valve 4D zoom, then again, you will get a 4D zoom with or without color. If you are in 2-chamber, click on left atrial appendage 4D zoom. You can do that. If you are in the bicaval view, you can just click on intraarterial septum 4D zoom. You will get an infasa of the intraarterial septum. So again, this is quickly cropping the area of interest with predefined anatomy or predefined parts of the heart that you want to crop. Then there's also manual cropping. If the crop that you've got here is not optimal, not what you wanted, you can even crop it one step further with 2-click crop. This is quickly, if you have this structure, let's say you want to focus, you want to look at the infasa at the mitral valve from here to here, then you just make one clip, another, and immediately you have an infasa from the surgical side. You can even have it from the opposite side, from the ventricular side. You can also have the 2-click crop focusing on the septum. If you want to see if there's any VSDs, for example, just make a click here and a click here. Immediately, you'll get a crop around the septum before and after the septum infasa of the septum. So again, this is an additional tool, very easy, very simple to use, straightforward. It's called 2-click crop. Just activate, place the starting point and the end point, and that's how you focus on your crop. Then we can also utilize 4D to go backwards into getting slice 2D planes that were not possible before or hard to achieve before. And this is an example of using flexi slice with laser lines. You can see the slice and you can see these long axis views where they are cut on the 4D volume. And you can also adjust one line here indicating that this is where the short axis is. You can see here, if I'm playing this slowly, this is one long axis view that I have of this left atrial appendage, but you can see the white laser line, this one here, which indicates where this long axis is taken is not in the proper place. I need to move the white laser line here, and this is what we are doing here. This is the white laser line, moving it here and aligning it so that we can get the perfect long axis view. Immediately, this is a perfect long axis view. However, now if you look at the short axis, this is the short axis, which is this image on the right bottom. This is a perfect short axis perpendicular to the neck of the appendage from this plane perspective. However, from this plane perspective, it is not, it is much longer. So once we adjust it, you will see even the length of this short axis has changed. So now we can be more confident in measuring diameters here and assessing the perfect sizing of the LA appendage closure device. And if we need one or two and so forth. So this is again using FlexiSlice to work backwards. This is post procedure, post implant, or during the procedure. As you can see, we can also use FlexiSlice to assess, for example, regurgitant jets or regurgitant orifice to get the perfect, again, short axis and perfectly aligned short axis for regurgitant orifice, whether it's an aortic valve or a peri or a paravalvular leak, as in this example, or even a normal vena contracta for a mitral valve regurg. Again, if you remember from last sessions, we spoke about PISA. If you apply PISA on this image here, your regurgitant orifice area will be actually this red circle, which is 0.7 centimeter. But if you apply PISA on the image on the bottom right, then your regurgitant orifice area will be 2.7 centimeters, which is this blue circle, which is extremely over-exaggerated, while the real area is actually this one here in yellow, which is, I think, 1.3 in this case. So FlexiSlice, again, can have many uses because it can give us different slices in 2D from the 4D data set. Another common use actually is utilizing FlexiSlice for mitral valve clip procedures. It's actually now a standard in the protocols of mitral valve clip procedures, where you can have 2 long axis views, 2 short axis views for guidance and assessment during the procedure. There's also another tool called 4D markers, where you can place markers, and these markers can be also aligned with pre-planned landing zones or just to mark a specific structure. This is right coronary ostium, this is left coronary ostium, and then whatever rotational cropping you do, you will not lose your perspective. You will always have the same marker as you are cropping and rotating. So you will not get lost when you start navigating in your 3D structure. Then you can also utilize actually the surface rendering for measurements, as in this example here, where you can actually get an in-FASA. Of course, when you're doing measurements on surface rendering, you try to be as much in-FASA as possible, because the actual measurement of the area that you measure is actually the equivalent of a projection on a flat surface from that 3D structure. So the more in-FASA you are, the more accurate your measurements are when you are trying to measure areas like this. Then there's also additional tools that can help in structural heart interventions. One of them is called VUX. We find that it is very common in structural heart echo lab or cath lab suits that the echocardiologist doesn't always get the privilege of seeing and following the cath image on the pendant. Of course, the echo image can be displayed on the pendant on the cath screen. However, the echocardiologist does not necessarily see the cath screen, trying to make space for the interventional cardiologist and assistants, surgeons, the nurses, and also the gantry of the actual C-arm, as well as the anesthetist in case there's anesthesia. So what we do with the VUX, we are able to derive the image from the cath and show it on the echo machine itself, and we can show it in many of the echo machines. So this way, we are able to follow the procedure as it's happening, see the advancements of the guide wires, and see when the device is being deployed, and then provide the right image, the right 4D acquisition to match whatever is being done on the cath also at the same time. So it improves communication and may help speed up the process. Then the topic of fusion also, of course, as we mentioned, CT is usually done pre-procedure. Most complex procedures, the planning is done on CT in advance. And of course, the actual device deployment is mainly done on either echo or cath. So both imaging modalities, also CT and echo, have the 3D volumic data with the possibility of 2D slicing. So why not fuse both CT and echo? And this is what we have with something which we call CT fusion. So you upload the CT images onto the echo machine, and you do the slice planes, the typical slice planes, the typical views, and the alignment of the 4-chamber, the 2-chamber, and so forth, and the annulus. And then you start acquiring. So again, you have all the data that you've planned from the CT, and you start acquiring echo, and then you again adjust the landmarks so that you have simultaneous navigation of the 4D data set and the CT with the same cut planes from echo and from CT at the same time as you are moving the slices from the echo. Even, for example, pre-planned landing zones that you do on specific CT softwares, such as the mitral annulus, the septum, the septal control, the vena contracta, the superior vena cava, inferior vena cava, even any 3D marker landing zones, for example, landing positions of an LA appendage closure or a TAVI, or even a simple pre-planning of the transseptal puncture position, for example. So you can, if you are doing an LA appendage, your septal puncture can be in the middle of the atrial septum. If you're doing mitral clip, for example, then the septal puncture needs to be a little higher. You can pre-plan that position on CT, and even the marker that you place for that can be also moved with the CT image onto the echo. As you can see in this example, this is where, for example, the landing zone is planned for a left atrial appendage closure device, and the sizing, of course, is done in CT already. So the size is already planned, the landing zone is already planned. So now that we have the same slice plane, cut plane between CT and echo, we can see exactly where we need to place the landing point, and then apply the procedure with even more confidence. Because, again, as I mentioned earlier, the complexity of structural heart is that every patient has different anatomy. These are different types of LA appendage anatomies that are totally different. And again, CT can help in the planning, echo can help in the guidance during the intervention. So you can see, first of all, the point, the pre-planned point of the transseptal puncture, and of course the landing zone where the device should be. And you see the slices, the maximum width of the appendage, and then in long axis, of course, and coronal, and even in short axis, if you position the white line differently, then again you can see the device as it's being advanced, and follow it through. The third area that 4D echo can help is in terms of quantification. Of course, there's the typical quantification tools that are in 4D when it comes to volumic and functional and so forth, but there's also the anatomical quantification. There's all kinds of quantifications, of course, and as you can see, AI is being used in all kinds, in most quantification tools, whether it's normal cardiac auto Doppler with or without spectrum recognition, or whether it's strain or chamber quantifications, or of course, in terms of structural heart disease, one of the most important is valve quantifications, aortic valve, mitral valve, and tricuspid valve quantifications, where we can get lots of information about the aortic valve sizing of the LVOT annulus and the bulb, mitral valve about the annulus, the areas of the leaflets and the diameters, of course, and the tenting height, tricuspid valve likewise for the annulus and the tenting height as well. We'll show you that in a second. Of course, again, AI has become now part of the echo exam with, for example, auto Doppler tracing for this LVOT. Again, whether it's transthoracic or transesophageal, we can utilize AI in cardiac auto Doppler to help in that aspect. 98% accurate, 100% reproducible, 3 times the inter-operator variability. These are, again, amazing tools. Even normal functional assessment, such as 2D, we spoke about that in the previous sessions. Even, for example, in 4D volumic assessment, this is an example of LV quantification from TE. So we assess the LV function, for example, pre and post procedure, if we're doing any procedure as well. Or if the patient has poor resolution, we can utilize 2D, 4D echo to get the right volumic quantification for the LV and the right ejection fraction quantification. There's also 4D auto aortic valve quantification, again using speckle tracking to track the endothelial or endocardiac border of the aortic valve apparatus, not the actual leaflets, but the actual annulus and the apparatus, hence serving as an adjunct to CT in the sizing aspect, as well as the length, for example, of the device that you are going to be used for closure, and the position, of course, during the procedure. Mitral valve quantification, again, assessment for each of the leaflets, anterior, posterior, all the diameters, all the areas, the tenting height, even the angle, for example, between the mitral annulus and the aortic ring or annulus. Helping in the quantification as well as the qualitative assessment of a prolapse if there is any as well. Likewise for 4D auto tricuspid valve quantification, again with the color coding of the tenting, just like the mitral valve, and of course the measurements and the areas and the perimeter of the annulus and the instantaneous annulus measurement between diastole and systole and so forth. Again, making it an easy way to assess the tricuspid valve on echo and 4D echo. So in conclusion, again, 4D or echo in general can help a lot when it comes to structural procedures in terms of the anatomical visualization, C-Sound, Vmax, HD Live in terms of the navigation when it comes to flexi slice, flexi views, or flexi slice, flexi views with automatic cropping, automatic orientation, flexi slice with easy slicing, getting the right anatomy or the right slice cut for the right anatomy. Then also during guidance for procedures, 4D markers, ViewX, and of course CT fusion, CT echo fusion with the benefits that we spoke about. Here are some examples. This is TAVR, pre-planned landing zone and sizing on CT, and then guidance in echo. This is an ASD closure with an Amplatzer device. Again, you can see during the procedure, one of the chutes is open. You can look at it from different angles, of course, because we are still positioning it for the other chute to open. We're looking at a side angle. Once you finish, you're looking at an in-face angle. So you can again imagine how the easy cropping and the two-click crop, for example, can help visualizing different angles of the view. You want to be outside of the device, but within the heart, so that you can have the right cropping, surface rendering. So again, having these easy tools for cropping navigation can help in every type of procedure. Again, just a simple thing such as a transseptal puncture, where you planned it here on the CT, you can see the same point on the echo, where this is where I want to do my puncture. And again, you can see the catheter that is going to do the puncture. You can see also the underlying or the walls behind, avoiding any trauma when puncturing from right to left. During the introduction of the catheter. This is an example of left atrial appendage, again using also CT fusion. So again, you can see the same cut plane in CT and in 2D echo, or it's 4D echo with the slicing from 2D, or the 4D surface rendering with multi-slice. And as you can see here, the original planned cut plane and landing zone, and this is post implant of the same patient and same device, but of course you cannot see the post implant on the CT because the CT was done pre-procedure. Mitral clip, again, flexi slice. You can see how flexi slice can help in the guidance of clipping. Do I have the right slice? Is it in the right position? Is the clip in the right position? Is it going to clamp now to the anterior and posterior leaflet? Is it in the right rotation also? We can see that in the other previous images. Is it in the right rotation? Is it at A1, P1, or is it at A2, P2, or is it, because we can see all these views simultaneously, as well as the surface rendering of 3D. So that makes a huge difference, to be honest. Again, we spoke about the surface rendering on the images. Again, you can see here, this is a post mitral clip, and you can see here there are two clips here. This is between A2 and P2, and since this is the septum, so this is also A3 and P3. And again, this is there's no clip, of course, between A1 and A3 and P3. I'm sorry. But again, you can see the residual area, the remaining area, let's say, of the mitral valve, to make sure that there is no, we did not cause a stenosis post-implant. Here, CT fusion is being used pre-assessment, and echo is being used during the Tendyne implant. And again, this is a post procedure CT view confirming what we have seen in the echo. So this is real-time example of a tendine implant. This is CT with echo, and you can see the annulus points between echo and CT are already co-aligned and registered. And this is during the implant, and you can see that there is no, or you can check visually the neo-LVOT to confirm that there is no neo-LVOT obstruction, making sure that there is a proper flow again during the procedure. This is a CT for a cardio band. You can see again in the CT, we planned exactly where are the staples or the anchors going to be for the band, planning this carefully, of course, on the CT image, which is again giving us the best resolution, so we can make sure each position of these anchors is going to be proper, no trauma, no fistulas are going to be caused or any other issues, so that you can follow the same planned landing zones. As you can see here, the same planned landing zone for each anchor. You can follow it as you are going along with the during the procedure to get the best outcome. This is, for example, also for sometimes in even more, let's say, complex anatomies, as in this example. This is an LV aneurysm. Again, CT helps define, and if you have the slices in the right place, CT with echo, because if you just look at the echo in this image, sometimes it can be tricky. So CT can help define exactly where's the area of aneurysm and guide in the event of intervention, closure device, and whatever you may have. So this is, in theory, these are the tools that we spoke about for the echo, how 4D echo can help in such structured interventions, and of course the future is here already with this example of CT fusion. There's even more tools are being built as we speak. But again, this is how much echo can help. It is on the spot, no radiation. It is real time. It can be 3D surface rendering. It can also have slices in 2D with flexi slice, with multi slice. That can give us a lot of information about the anatomy and the structure and guidance also during the procedure of the position of the landing zone, of the sizing as well, and checking the outcome on the spot upon implant and post implant as well. So this is pretty much what we have in theory, but I'll show you some of the examples in terms of navigation and cropping on the EcoPack. I believe most people have already joined the previous sessions, so I'm not sure if there's a lot of need to show all these examples again, but if there are new members, please do let me know. We can go over again many of these examples in terms of navigation, cropping, even quantification on the EcoPack, where you can get even a better idea how Eco can help again in such procedures. But before that, I would like to open the floor for any questions or comments. We are more than happy to hear from you instantly, your feedback and your thoughts about what we have discussed. So if I may, sorry, let me just close these files. Okay, so any questions or comments? Stop sharing for a second. So we are open to any questions or comments. You can also write whatever text you want. If it's a question or comment on the chat box, you can raise your hand or just unmute your microphone, and I'm more than happy to answer any question or comment you may have. Okay, so let's go through some examples. Alma, can you just confirm my audio is still hearable? You can still hear my audio?
Yes, Judith, I can hear you.
Great, thank you very much. Yeah, so let me show you some examples of what we were talking about in terms of navigation, cropping, as well as quantification. So here are some views. Let me just find the right data set. Okay, so we'll show you some of the quantification tools. One of these examples is, for example, mitral valve quantification. So here we have an assessment of this mitral valve. We just go to valve, and I'll show you how quick and easy to do, even in a complex anatomy such as this abnormal valve, Marfan disease, I think this is. Right, so we go to mitral valve quantification, and then we do a little bit of alignment so that we can have the right
Judith, are you sharing your
structure with the
screen?
right positioning.
Are you sharing your screen? Because we can't see your screen.
Okay. All right. Now I actually stopped sharing for a second. So let me share my screen again. All right. Now I'm sharing. Can you see my screen now?
Not yet, but it's coming up. Yes, we can see
Okay.
it now.
All right, great. So this is an example of 4DTE, and this is the quantification tool, which is called mitral valve quantification. And you will see the quick and easy adjustment for processing the speckle tracking, because all of these tools rely on actually speckle tracking in order to do the proper assessment. And now we just need to set the landmarks of the insertion points of the different leaflets. Coaptation is here, aorta, and speckle tracking will work in a second, and it will actually track the entire apparatus, the annulus, as well as the cusps, and you can see these cusps from different positions. Actually, this is one of my favorite views. This is the scallops. So here you can see the yellow line is A1, P1, and then the green one or the green plane, which is A2, P2, and then the blue one or the purple one, which is A3, P3. And you can see the actual anatomy of the structure of the mitral valve in systole, and you can see it's actually bulging towards the aorta, and you will see that in the results with the color coding. You can see the color coding; it's all red. This is all prolapse. The whole valve is prolapsing during systole. So you can see the tenting height is only 0.3. It's actually a reversed tenting height. It should be 1.2 on the other side, inside the ventricle. And you can see all the parameters, the areas, the leaflets, for example, the anterior leaflet area versus the posterior leaflet area, all the diameters, all these quantification tools, and of course the annulus area and the where's the annulus? Here's the annulus area in 3D and 2D as well. All the parameters are given in a few seconds, as you can see, just by going through the quantification. Likewise, for the aortic valve, I think this is an example of aortic valve. Yeah, so, and this is also another example. Here's aortic valve at 56 frames per second, as you can see. If we go to valve quantification, AVQ, aortic valve quantification. This is a very small zoom, so it might not be aligned properly, but we can fix the alignment. So now we have the different, oh, sorry, I think I selected different. I think I selected tricuspid valve quantification. So here's aortic valve quantification AVQ. Yeah. So the annulus is here. This is a coronal plane. Perfect. VOT segmentation. And you will see the speckle tracking. It will start working for all this aorta, including the LVOT. And I can make adjustments for any zone that I don't feel is right. And then we can go to measurements. And here you will see the aortic annulus diameter, 25.5 millimeter, maximum diameter, aortic annulus area 5.2 centimeters. So you can see the area 1 millimeter before the annulus, and each millimeter before that in the LVOT, and then the increasing area as we approach the maximum of the bulb at the ostium of the coronaries, where the maximum area is around 7.5 square centimeters, and it's 1.1 millimeter away from the annulus. So the maximum area is actually, which is almost here at the ostium of the coronaries, and that area is actually that is 1.1 centimeters away from the actual annulus insertion of the coronaries. You can see here one coronary insertion. You can see the other two here and here. Again, all these quantifications given in a few seconds, and you can see it's using speckle tracking to do all this assessment. Let me see if we have a tricuspid valve as well, where we can do quantification for the tricuspid valve. I'm not sure if I have one here in this example. I think in a different file there is one, or probably different study. I think there is one here. Let's just wait for it to open. Okay, there are some examples. This is an example of a mitral clip. Yeah, this is during mitral clip procedure. You can see, we can visualize from different angles. You can see that the clip is still actually inside the atrium. It hasn't been advanced into the ventricle or across the valve. But let me show you what I'm looking for, which is actually a tricuspid valve, to see if we can utilize tricuspid valve quantification. This is aortic valve. This is I think this one is a tricuspid valve. Yeah, you can see this is a tricuspid valve. So we can go to measure. We can go to valve for the auto tricuspid valve quantification. Again, apologies for the lag and the delay. This is because the graphic card is busy sending the images as well as trying to display 4D loops. So here I just follow the pictogram, trying to create a 4-chamber view with also a 2-chamber view here. And this point should be in the middle of the tricuspid valve. And then I can go to set landmarks, or I can go to here, 1 point, here another, and here free wall, septum, and coaptation. And you will see the speckle tracking will start working. And here's my tricuspid valve. And here's my full anatomy. So again, this is the free wall in orange. The septum is in yellow. So if I want to look at it from the ventricular side, this is looking at the apparatus from the ventricular side. The anterior is green, the posterior is pink, or if I rotate it, then I'm looking at it from the atrial side. Yeah. So, but most importantly, if I go to results, then I will see all the parameters the annulus area in 2D, perimeter, the annulus area in 3D. We can also see the different area in time. We can also have information about the coaptation point height. You can see that here, as well as maximum tenting height, tenting volume, 2.1 mLs. Again, all this, the parameters you can have in a fraction of a second or a few seconds, as you can see, and the quantification, mainly the annulus quantification for tricuspid valve. In terms of cropping, you can see here, for example, this is another data set or 4D data set, and now I can choose, for example, here, right away on the spot, let's say I want an infasa at the aortic valve. So I can just go here in the 4D, I don't see the aortic valve anywhere. If I could just go 2-click crop and I make 1 click here and then another click here, then I have an infasa of the aortic valve from the ascending aorta position. And you can see the cusps opening my way. And this is, again, this is not a normal, of course, anatomy and view. We can also increase the gain so that we have more fill-in for the aortic valve to reduce that. It appears as if there is perforation, because the gain was too low. And the reason was that we were looking at the mitral valve. When you are looking at the mitral valve, as you can see here, the noise can obstruct the vision of the mitral valve. So in general, the trick is always try to acquire a little bit overgained rather than being undergained. And again, we mentioned that several times in the previous sessions in the 4D echo navigators in the first course and the second course that we spoke about 4D echo here. Okay, so you can see an infasa from the ascending aorta. So you can see the cusps opening again in my face from there. I can go to flip crop, then I look at it from the other side. So this is from LVOT side. And again, this is the anterior mitral leaflet. And again, this is the septum. So this is the non-coronary cusp. This is the left, and this is the right coronary cusp altogether. Or I can just rotate it manually if I want to. Then again, I can see even the coronaries as well. Yeah. So then I can go to another example. Here, this is left atrial LAA closure device. Sorry, I thought it was an intra-atrial septum. This is an LAA closure device, as you can see. Here, another example of, again, this is also a left atrial appendage closure device with a mitral stenosis. Here, this is an abscess inside the left atrium, as you can see. And if you apply FlexiLight, you'll be able to see that even better. You see, look at the shadowing effect now with this abscess. So you can see that it is totally different. Applying the FlexiLight gives us a real true different indication about the different anatomy. So again, all these tools, whether cropping, navigation, or quantification, can help in the assessment guidance of different structures, different anatomies. And again, as we mentioned earlier, quantification for the valves. This is another example of a tricuspid valve with, I'm sure there's a severe functional AI. Yeah, this is pre-clip procedure. You can see there's no coaptation, or there's a lack of coaptation of the cusps. Of course, the gain is a bit low, but if you increase the gain a little bit, you will see there is still a lack of coaptation in the tricuspid valve. That's it from my side. I try to make it as short as possible, light as possible. I know it's a long day. We are approaching the weekend, so thanks again for joining this fifth session of the series of this series of the ACE courses. We are open for any questions or comments.
Hi, I want to ask, but if these sessions will be uploaded on the Vivid Club?
I'm not sure if it will be uploaded on the Vivid Club, but on the landing zone that we have where you made the registration initially, we will have all the recordings of this session uploaded so you can review them over again.
How can we review it again? From Zoom also?
The landing zone, remember the PDF, the first PDF that you received where you made the registration?
Yes.
Yes. Next to the sessions, we will have icons for the registration. Let me just open it real quickly just to show you the. Sorry. This landing zone. Oops. The website, the landing zone where you made the registration, which is this one here. And you can see the different courses. Next to these, we will have also the actual recording of all the 5 courses. So of course there will not be any more registration, but you will be able to see the recordings of the sessions. So our team will upload them. We were waiting actually for the end of the session so that we can have the recording, and our team will upload all these sessions on the website.
Excellent, thank you.
Thank you. Any other questions or comments? Sorry, I cannot see the chat box. I'm just having to move my camera so that I can see the chat box if there are questions or comments. Yes, we will share it on the registration page. Sure. Okay, great. If there are no more questions or comments, we'll be happy to end the session, and really very excited and very happy to have all these. There's one more comment. Any certification for this? I don't know about the certification. I can check with our marketing team if there can be certificates. Yes, we have the attendance of all the sessions, so I believe yes, it is possible. But since it's virtual, we can also make a certification that mentions virtual. So yes, it is possible. We usually give certificates for the physical courses that we give because there's also lots of hands-on. We do all the cropping navigation with our own hands on an eco pack in the physical sessions. But of course, since this is a huge region, we opened it to a huge region. It's not possible to do it physical, but hopefully in the near future there will be more physical sessions. Can you share the link to upload videos via email? Of uploaded videos. The link is, yes, we can share it by email to everyone who registered. We can send it to you, to everyone registered so that they can access it again. It's again the same link from the original email that you received for the announcement for the course. It will be in the same landing page or registration page of the series of the courses. Any other questions or comments? Great. Thank you very much. Again, one more question. Happily, thank you very much. Thank you. Thank you very much. I'm so happy we have finished the fifth session, but hopefully we are in discussion of PASCAR again to repeating all these 5 sessions, hopefully within the next months. And there will be also additional announcements for different regions and zones as well for these courses as well. And of course, as always, we try to make it open as per your convenience wherever you are to join these courses anytime. Again, thank you very much. So happy to bring this to conclude the last session of this series. Again, I would like to express my gratitude to Dr. Elijah, to George from PASCAR, who have helped and facilitated and enabled us to do this invitation to all the PASCAR members and to do it in collaboration with them and all the experts who reviewed the material and the content and approved and endorsed it. And we hope to have future collaboration with PASCAR and other societies in the region. Thanks again for all the time. Thanks for all our GE team that has been working in the background, planning and building all these websites and all this material and the links and the emails that you've been receiving automatically and the Zoom invitations and the work that they've done with this. Really appreciate everyone's support and help. It's been really a great effort and hope to repeat it again and bring you more of these virtual courses as much as possible. So again, this was ACE, that Advanced Courses in Echocardiography. And again, thanks for joining this last session out of 5 series that we have done in collaboration with PASCAR. Have a good evening and thanks again.